Utah politics. We begin this morning with Brian Shiwazawa, former regional director for Health and Human Services. Also, you may know him as a former state senator. He's here to discuss all things healthcare. Brian, great to have you back on the show. It's been a few years.
Great to be back, Glenn.
Yeah. Excited to catch up with you, talk a little bit about your experience with HHS. Just kind of give us a little update on how that experience went for you.
Well, that was a very positive experience to be able to serve with the Secretary and work with Health and Human Services, which, by the way, is 80,000 federal employees scattered over 10 districts and a $1.3 trillion budget.
Wow. Hard to even wrap your mind around that one, right? Okay, so you were the regional director based out of Denver, but you oversaw a western region.
That's correct. So our headquarters was in Denver, but the states that I oversaw were Colorado, Utah, Wyoming, Montana, North Dakota, and South Dakota.
Got it. Certainly a lot of things happened during your time there. Let's start with one of the top issues we've been dealing with for quite a long time. That's the Affordable Care Act, Medicaid expansion tied to that. What did you see as far as the Affordable Care Act? Do you believe it is helping people? And what about, the current administration continuing to chip away at it?
Well, regarding the Affordable Care Act, what we saw firsthand in this region was that there are very big health disparities. For example, if you compare in the state of South Dakota, the average life expectancy in, say, Rapid City, among a white population, it's around 78 years. But if you go just south to the Oglala Sioux Reservation, under Indian Health Service, the average age expectancy is about 20 years less, or 58 years.
That's a
huge
big discrepancy. Okay, so when you talk about the Affordable Care Act and Medicaid expansion, how does that apply into a situation like that?
What we saw was an interesting contrast between the state of North Dakota, which has expanded Medicaid, and the state of South Dakota, which hasn't. And in fact, the Native American populations, to just focus on them, for example, had better health care services. In other words, the Medicaid supplemented the Indian Health Service and led to overall better health care for that population in North Dakota versus South Dakota.
You are well aware of the situation here in the state of Utah. You ran a bill to expand Medicaid when you were a state senator. You know it was passed via ballot initiative. What are your thoughts as you take a look at what's happening here in the state of Utah? You know the legislature modified it. It appears to be back on track to go back to the ballot initiative. Your thoughts on that?
Well, it looks like that with the bridge waiver that was approved by the Secretary, that there are already 35,000 or more Utahns who were formerly on PCN, Primary Care Network insurance, now on Medicaid under the match that we're currently having. So in other words, there's more Utahns currently under even the current Medicaid law. Now there's some waivers that Utah is requesting from the White House and from the Secretary, and we'll remain to see how those pan out.
We estimated that there might be some 70,000 Utahns being on the Medicaid rolls, however. So we're seeing a much lower number than what we thought through the end of the year anyway. Do you believe the legislature should have just left the ballot initiative alone, or do you like what you saw in the way they modified it?
Well, speaking as an individual taxpayer and one who's looking at the Medicaid expansion, I like the Medicaid expansion for the benefits that it brought to that population, given that we're already paying taxes on this in various forms to support the Affordable Care Act. And so it always has appealed to me as a former legislator and as a taxpayer in the state of Utah that we would take our own tax dollars and use those to help our underserved and poor population here within the state. So that made fiscal sense to me, that made medical sense to me.
You ran a bill, as I mentioned, basically was along the lines of the Healthy Utah plan, where it would have covered up to 100% of the FPL, and then 101 to 138 would be on the exchange. Do you think that's the best option, or from your experience with HHS, did you see more benefits up to 138%?
Well, it certainly makes it easier for states to administer when you go up to 138%. On the other hand, the benefits that would accrue to the state of Utah under either scenario, I think, would be significant. In other words, we would have tens of thousands of Utahns with some type of Medicaid health insurance, which would basically keep them out of my ER in a lot of different circumstances.
Did you find by and large, however, that those at 101 to 138 could afford to be on the exchange?
Given the supplementary benefits that came to that population, it helped them a great deal. And so that was one of the big benefits to that population.
Okay. Measles outbreak. We started to see that recently. Really didn't expect to see that. Your thoughts on what you saw there and moving forward?
Well, measles, first of all, we know is a very serious illness, especially in children. But the other part of it is it's completely preventable. And so the Secretary has endorsed, and I agree with, having vaccinations, using the MMR. We know that it's a safe vaccine to go forward and that it helps prevent measles outbreaks through that concept called herd immunity. In other words, if more people have the vaccination, then less likely an outbreak would happen. And if you fall below a certain level, say about 90% of the population, then you have the risk of an outbreak.
Big talk about affordability, out of reach for some folks. Let's talk a little bit more about that, because now your new role is with the University of Utah Health as VP of Health Policy. Is the industry doing everything it can to drive down costs, both for medical care and prescription drugs?
Healthcare costs are a huge issue, and in fact in 2020 will be a big issue, whether it's single payer sort of insurance or whether it's the current method we go forward on. But we need to work on healthcare affordability. The Secretary has said, and I agree with him on this, if you get, for example, a prescription written, but you can't afford that, say, insulin prescription or blood pressure medicine, you might as well not be treated. You've got to have prescription costs, healthcare costs affordable so you can take advantage of this great system we have for your health benefits.
You've been on the front lines as an ER doctor. Again, is the industry governing itself and doing everything it can to make sure that people can afford their insulin and other, life-saving medications?
Well, we've certainly left the insulin population there in limbo, because what we've done is we've let the cost of insulin go up, even though this drug has been around for 90 years. And yet now we see many families who can't afford basic insulin. And so they either ration it, meaning they don't use it as much, or they simply don't buy it. And then all the complications that can come from diabetes and undertreated.
What are the answers? In the state of Utah, we've run bills to open up a pipeline for cheaper Canadian drugs. What do you see as a solution there?
Well, there's a lot of things that the policymakers have options to. One is, as you mentioned, drug importation from foreign countries. Another is to encourage competition among the pharmaceutical companies to bring the costs down. Other ways are innovative, like the PBMs, the pharmacy benefit managers, to make those more transparent. There's a lot of different ways that we can go forward to improve this, make it more efficient and lower costs for the patient.
Yeah, we've seen some bills run in the state of Utah eliminating the middleman and trying to pass those on. We will watch and see what happens. So much more I'd love to get in with you, but unfortunately, we've run out of time. It goes like that. Great to see you, though.
It's great to see you, Glenn.
All right.